Our next presenter is well known to most of us. Dr. Vivek Misra is a vascular neurologist at the Houston Methodist Neurological Institute. He is an associate professor of clinical neurology at Weill Cornell Medical College. He completed his neurovascular training at the University of Texas Health Science Center in Houston as a Spatrius Fellow, which I understand is a very elite group of individuals. His clinical and research interests include management of acute ischemic and hemorrhagic stroke and stroke recovery. He is actively involved in the training of neurology residents and fellows. He is also currently involved in StrokeNet and has personally ridden in the mobile stroke units that he's about to present. So Dr. Misra.
Thank you, Dr. Bruce. And it's a pleasure to be here. And when we talk about the future of stroke care, it has to involve, in my opinion, mobile stroke units, which does include treating acute stroke patients in the pre-hospital phase, even before they get to the hospital. So these are my disclosures. And when we look at the stroke prevalence in the United States, almost 1/3 of these patients with ischemic stroke, they have what is called as large artery occlusions with higher NIH stroke scales. And then 2/3 of these patients have relatively low NIH stroke scales, relatively mild strokes. But regardless of stroke severity, all these patients, they do have neurological deficits and disability if they're not treated adequately and accurately. And when we look at all available treatments, we still have only 2 treatments to treat acute stroke patients, which is TP and mechanical thrombectomy. And the American Heart Association also has the saying that spot a stroke fast, because these treatments, their efficacy is highly time sensitive. When we look at all the patients who've been treated in all these clinical trials, all the registries, the benefit of TP is highly time sensitive. With every passing minute, the benefit of treating patient diminishes over time. There was a study from Asia in 2015, and they also looked at the efficacy of TP actually dissolving a clot. And what they found is that the longer you take to expose the clot to TPA, the less is the probability that TPA will actually dissolve the thrombus. So we can also say that apart from time is brain, time is also clot. And the same thing stood for mechanical thrombectomies. The longer it takes to access the groin to perform a thrombectomy and open the artery, the less is the probability of a good outcome with stroke patients. So then the stroke system of care also evolved into telemedicine. This is the present stroke care, in which a stroke expert using telemedicine can reach out to patients remotely in rural hospitals, make decisions for TPA or thrombectomy, and then depending on the situation, they can have these patients transferred over to a comprehensive stroke center and make decisions on what else needs to be done for those patients. But this is still the present status of stroke care. So moving on to mobile stroke unit, what is a mobile stroke unit? It's a specialized stroke ambulance, and it was first conceived in Germany in, I think, 2012. And they named their project as STEMO, or stroke treatment in the emergency phase. What they did is, inside the ambulance, they fit a CT scanner. So the way the mobile stroke unit works, and as you can see, when the 911 call is called, the STEMO or the mobile stroke unit heads to the site. They put the patient straight on the CT scanner. On the CT scanner, they immediately do the CT scan, and then the paramedics, they connect the telemedicine equipment, which you can see in the 4th image below. And once the equipment is connected, the stroke expert can then remotely through telemedicine start examining the patient. All this activity is done within a few minutes of the onset of symptoms, and the stroke expert then can start intravenous TPA infusion. You can also do a CT angiogram in the ambulance. You can alert the thrombectomy team, and based on the situation, if the patient does have a large vessel occlusion, we can then take the patient straight to the angio suite for thrombectomy. So the initial results from Germany were quite promising, and they showed that the proportion of patients who got TPA within the golden hour was 6 times if it was done through a mobile stroke unit level of care compared to the conventional triage. And this was done without compromising safety. So there was no increase in mortality or morbidity with the mobile stroke unit system of care. They found that their patients were more likely to actually walk home from the hospital as opposed to going to a nursing home or going to rehab. They also found that a large number of patients who still had large vessel occlusions, they actually went directly to a stroke unit instead of going to an emergency room which did not have stroke expertise. And most importantly, there is the ability to diagnose an intracerebral hemorrhage within minutes of the onset of symptoms. So they could bypass a lot of centers which did not have neurosurgical expertise, go straight to a center where there was neurosurgical expertise available. So this map shows the mobile stroke unit sites all across the world. You can see the vast majority of these are in the United States, several of these in Europe, but we do have quite a few of these in Asia and the Middle East as well. It's a little old map in 2018, and in the last 2 years this map is now more populated. So, I'm happy to say that mobile stroke unit sites are now getting more and more populated all across the world. So what is the impact of mobile stroke units in stroke care? We now know that with MSUs, there is faster thrombolysis without impacting safety. This was first shown in Germany, and then the second site to show was our own site in Houston, and it has also been corroborated by other institutions all across the world and the United States. We've also shown that mobile stroke units can function effectively using telemedicine. In fact, the MSU in Houston compared telemedicine mobile stroke units with a neurologist who's sitting in the ambulance making decisions for TP or thrombectomy in the ambulance, and we found that you really don't need to position a neurologist in the ambulance. The same thing can be done remotely through telemedicine with mobile stroke units. We also do CTAs in the mobile stroke unit, and this has resulted in shorter door to puncture times, and these patients then do get faster thrombectomies. This was first shown by the mobile stroke unit in Tennessee, Memphis, and then the next institution was the Cleveland Clinic, and then it has been corroborated at other MSUs as well. Data from all the MSUs all across the United States has shown that this level of care is highly effective in rural, in suburban, as well as in urban settings. So whether it's in Houston or it's in Lubbock or Amarillo or even remotely in any part of Texas, any part of the country, MSUs are equally effective. But what we have to consider is the cost of MSU care. A single MSU costs around $1 million. So when you put a CT scan, you put all the technology in the ambulance, the cost can be quite prohibitive. So what we also have to see is when we treat patients much faster, we are also reducing their disability. So long term, you're reducing the overall expense of taking care of those patients, all the disability involved. So what has to be seen is the highly expensive MSU level of care, does that initial expense offset the eventual cost which does come when the entire system has to take care of patients who are disabled, who are paralyzed? So this was done through a study which was done here in Houston, the BEST MSU study, and this was conceived by my mentor, Dr. Grada, and this study involved collaboration from all the institutions here in the Texas Medical Center, including Methodist. There was also collaboration from the fire departments of the city of Houston, the city of Bel Air, and West University. And this study was initiated in 2014. We completed this study last year in 2020, which is not too long ago. And we also have the long-term results. And I'm happy and proud to present the results that this study found significant benefit in patients getting treated with TP and thrombectomy. TPA particularly within 60 minutes of the onset of symptoms. We found several more patients walking home as opposed to going to a nursing home or going to rehab, and this study has been now submitted for publication. And I think the next step would be is based on the results of this study is how do we mobilize support for developing MSU level of care all across the country. We also have an organization called Presto. So this is the Prehospital Stroke Treatment Organization. This was conceived in 2016, and it's an international consortium of medical practitioners who are involved in pre-hospital treatment of stroke patients. The goal of the organization is to mobilize lawmakers to involve everyone who can help with establishing MSU now as the stroke system of care and further build on this in future. So this is a clinical case. This is one of our patients from the Christmas long weekend. This is a 38-year-old female who was visiting Houston from New Jersey. She had sudden onset of aphasia, right hemiparesis, and this was at 3:45 p.m. The EMS were called, and then they activated the mobile stroke unit. The NIH stroke scale was 12, primarily for aphasia, right hemiparesis, and then we did a CT head at 4:15 p.m. as well as a CTA. And in this image, you can see that this patient, this young patient, had a left M1 occlusion, and this can be one of the most severe strokes that we can treat. TPA bolus was initiated at 4:30 p.m. and when the bolus was initiated, the patient was en route to the emergency room at Methodist. The patient reached the ED at 5:11 p.m. and went straight to the angio suite for potential thrombectomy. And when the angiogram was done, you can see the angiogram, the left M1 is open. So this was a spontaneous TK3 reperfusion with a large clot which was occlusive, a left M1 occlusion. The NIH stroke cell at 24 hours was 0. This patient had recovered nearly completely from her deficits. And you can see the MRI scan at 24 hours, and we see just a small stroke in the left subcortical region. Additionally, this patient was found to be COVID positive with a PFO. But this demonstrates the power of using TPA in the golden hour. There are patients, if the TPA, let's say, does not dissolve the clot, with the MSU level of care, you can achieve faster thrombectomies and improve outcomes with these patients. So what about acute intracerebral hemorrhages? These strokes are the ones which have the highest mortality and morbidity, and this largely has to do with the fact that there is early hematoma expansion. When the bleed starts, there is rapid expansion within the first few minutes to few hours, and you can see from the CT in one of those patients, this patient had a right basal ganglia bleed, and by the time this patient got to the emergency room, this was within 1 hour, the initial hour, you can see rapid expansion of this hematoma with intraventricular hemorrhage, with hydrocephalus, and this is what really results in high mortality and morbidity in these patients. So with mobile stroke unit level of care, you can diagnose these patients much earlier, you can initiate antihypertensive treatment much earlier, and patients who have coagulopathy related bleeds, these bleeds, you can really reverse the coagulopathy much sooner, even before they can get to the emergency room. And I'm also happy to mention that this concept of mobile stroke unit in intracerebral hemorrhages will also be used in the fastest trial, which will investigate NOVA 7 in a time window now of 2 hours. So finally, what are the other future steps with the mobile stroke unit? We know that acute neuroprotection has not been successful in stroke medicine, but we now have the ability to be able to use these neuroprotective agents much sooner within the golden hour and investigate whether they'll be useful. Thank you.